health equity, social health, and a number of clinical areas as well. You have joined just final verification, similar to what they do on flights and stuff. You all have boarded for federal and state collaboration around health-related social needs in Medicaid. It's now or never, folks. So if you need to get up, now would be the opportunity. I am thrilled to be joined by a number of colleagues from state and federal government who are tremendous partners in this work, both at the policy and the implementation level. So what we'll do is, let me just briefly introduce who we have on stage with us, and then I'll come back for some framing remarks and we can kind of launch into the discussion. But in order from stage right to stage left, so to my immediate left, Dr. Gary Singh from MassHealth, Shavana Howard from the U.S. Department of Agriculture, Food and Nutrition Consumer Services, Richard Cho from the Department of Housing and Urban Development, and Jacey Cooper from the California Medicaid. Let me start by giving a bit of an overview on where we are with the coverage of health-related social needs in Medicaid and CHIP. In the last few years have made tremendous headway in terms of, in particular, covering those services with federal match dollars. There is a long history in the Medicaid program of recognizing the importance of upstream services like housing supports or nutrition supports, in particular, for those that are familiar with Medicaid, in particular in the home and community-based services waiver setting. What these new policies, both in managed care and Section 1115 demonstrations allow for is the coverage of those services for really broader populations that are at clinical or social risk, in recognition of the fact that health-related social needs drive as much, actually, if not more, than clinical care does in terms of an individual's health outcomes. We have new flexibilities in Section 1115 demonstrations to cover those services, inclusive of housing services such as short-term post-hospitalization housing, nutrition services like home-delivered meals or medically tailored meals, alongside case management services and care coordination services to really wrap. As we were, and then on the managed care side, through an authority called In Lieu of Services and Supports, that allows managed care plans to work with their enrollees to offer those services as substitutes for other Medicaid state plan services. We are joined, as I said, by folks from the federal and state government who are really at the leading edge of that policymaking and of that partnership. So without further ado, I will kick the first question to Gary. What I hope you will see over the course of this discussion, and we really do want it to be a discussion, so please be writing down your questions as we go, is there's a real intentionality to who is on stage here. So both Gary and Jacey, being from Massachusetts and California respectively, are in states that, as I said, are really at the leading edge of taking up these policies. And we'll have them speak to how they thought about scoping these services, how they thought about the different authorities that they could use and bring to bear, what it was like to get stakeholders on board and now in the early implementation phases of doing that work to benefit enrollees. We also have Shavana and Richard here as federal partners from USDA and HUD respectively to speak to how the Medicaid piece is complementary to and kind of can wrap around or sit alongside the really important existing programs that HUD has, the really important existing programs that USDA and FNS has. Because I think if you hear me say nothing else in the context of this, it is that partnership and really intentional collaboration and braiding and blending of funding, data sharing, right? Things that are really key enablers to actually making this work at a ground level and taking the policy really into practice. So with that, Gary, first question for you. Can you tell us a bit about the Massachusetts experience, sort of how you thought about the set of services. Share maybe a little for everyone what is in the 1115, what you all have been doing, and how that came to be, how you thought about scoping those services.
Thank you. So as Aditi mentioned, my name is Gary Singh. I'm the Senior Director of Strategic Initiatives at MassHealth. And we provide coverage for a little less than a third of the state's population. So to your question, back in September of last year, CMS approved our newest iteration of our 1115 waiver, which for those of you who don't know, is basically like a contract between our Medicaid agency and CMS on different ways, among other things, that we can implement new and innovative approaches for administering a Medicaid program other than the standard way of doing so. And one of the most cutting edge aspects of it was being able to use Medicaid dollars and to use those to pay for certain health related social needs like housing supports and nutrition supports. And though I tend to think about our recent approval as authorizing phases 3 and 4 of our housing journey for the non-dual eligible Medicaid population, and phases 2 and 3 of our nutrition journey. So I'll talk a little bit about what all of those phases are. And this gets to what services we have approved and what populations they're targeted towards. So on the housing side of things, phase 1 began in 2005 when we began introducing housing benefits or supports into our behavioral health managed care structure for individuals who are chronically homeless. And the services were to help them look for housing, transition into housing, and then to receive life skill coaching to stay in that housing once they moved in. And then, over the next decade and a half or so, we sort of progressively expanded that behavioral health managed care benefit to more plans within the MassHealth context. Phase 2 began in 2020 through something called our Flexible Services Program, which was a pilot program also authorized under 1115 waiver, where Medicaid Accountable Care Organizations, or ACOs, a particular kind of health plan, could use those dollars to pay for a broader set of services for a broader population. Now, I do want to call it, this was a pilot program, so it wasn't a benefit like the phase 1 services were. But the Flexible Services Program allowed these ACOs to provide housing supports for folks with needs other than behavioral health. So it could be physical health needs, high ED utilization, folks with a need for support for activities of daily living, or experiencing a high-risk pregnancy. And the services are, in addition to that, it wasn't just targeted to individuals who are chronically homeless, but could meet other levels or standards of homelessness, as well as people who are at risk for homelessness. The services provided there, again, through this sort of pilot effort, include the same services as phase 1 services included, but also eviction prevention services for those folks who are at risk for homelessness. And then also, really importantly, we could start paying for goods. So what do I mean by goods? So let's say that someone's moving into an apartment. There's nothing in the apartment. So can we pay for things to furnish the place? It could be used to pay for first and last month's rent, as an example, and could also be used to pay for things like home modifications or air conditioners to help folks with asthma, as an example. Phase 3, which was one of the phases that was authorized through this most recent approval of our 1115 waiver, expanded the number of services that were in the benefit. So previously, phase 1 was focused on chronic homelessness and the behavioral health managed care world. Phase 3 expanded it beyond the managed care world. So now anyone at MassHealth who has a behavioral health need could qualify for some of these housing supports, regardless if they're managed care, fee for service, et cetera. In addition to that, we expanded the eligible population from the chronic homelessness slice to also include folks who were quote unquote just homeless, but high utilizers of healthcare. And then we also added some eviction prevention services to the benefit as well. Phase 4, there's a lot of phases here, I recognize that, is going to begin in 2025. And this is when we take all of the services that I just described in the first 3 phases, we're going to mash them together into a unified HRSN services framework where we will be we'll be putting all of these things into the managed care structure, such that we'll be needing to think through, medical necessity criteria, provider qualifications, claims adjudication, rate setting, network adequacy. So the standard things that are part of a managed care framework. One of the wrinkles is that in this phase 4 world, we have a limited amount of funding or expenditure authority. So we're trying to figure out, how do you implement in a managed care structure when you actually have a funding cap? So that's one of the things we're struggling with, or thinking through on the housing side. On the nutrition side, phase 1 began in 2020 with the flexible services program. And so for there, we again, were able to work with our ACOs to pay for actual food goods. So medically tailored meals, food prescriptions, food vouchers, community CSAs. And then in addition to that, nutrition education and counseling and kitchen supplies as an example. And then for both nutrition and housing, we were able to provide transportation supports to actually access those housing and nutrition services. Phase 2 of our nutrition journey, which again was authorized as part of this most recent 1115 waiver approval, allows us to do something that was the most requested thing that we heard about from stakeholders in response to our phase 1 nutrition rollout, which is being able to provide household level nutrition supports. As is sort of intuitive, if someone is hungry and they live in a household, they're going to share their food if they receive it. And so in some ways you can think about that as diluting the nutritional intervention. So in phase 2, beginning in April of this year, ACOs will be able to use some of their dollars to pay for nutritional supports for household members other than the actual individual Medicaid member. And then phase 3, we've already talked about beginning in 2025, we're gonna cram this in with the other housing supports into this unified HRSN services framework. I'll just touch briefly on the stakeholder piece and then I'll hand it over. This rollout of these multiple phases has definitely been a journey in Massachusetts. And we have been very intentional about trying to engage with the community, with our managed care plans, with our community-based organizations that are actually helping us to implement, to provide these services. And one example of that is we have procured what we call a social services integration work group made up of all of the different players in the space to help advise us on policy design, implementation details, and those sorts of considerations. And as we begin to prepare for this 2025 date, we intend to procure a similar group to help us to think through some of those additional considerations. So we're really excited about the trajectory for both of the housing and the nutrition elements, and grateful to CMS and their federal partners for helping to move us in that direction.
Thank you, Gary. Shavana, tell us about, from USDA's perspective, maybe an overview of the nutrition security programs or the programs that would, for a similarly eligible population, be brought to bear, and an overview really of what FNCS is trying to do.
Sure, thank you. And my name is Shavana Howard. I'm a senior advisor for USDA. I work very closely on SNAP. I also have over 20 years of state experience administering the SNAP program in the states of Louisiana and Washington State. And so, for decades, SNAP has been really working to fight poverty and hunger. Can you hear me okay? Okay. And so we continue that fight of really trying to increase food and nutrition security, as we have been doing for decades. And we do that through a plethora of programs. I know you often hear likely SNAP as the #1 program within USDA, but there are actually 16 food programs within USDA, SNAP being the largest program that really responds to poverty and to hunger. In SNAP, we serve about 42 million households on our program, with 42% of them being seniors and 41% of them being children. And then a lot of our population is honestly the working poor, who is working, jobs that are just at minimum wage and can't meet ends meet. Within SNAP, like I said, there are a lot of programs, and I'll just touch on just kind of a few. Although SNAP covers and touches so many individuals, there's 1 in 4 people who are actually eligible for SNAP that are actually on the program. So there is an access issue with individuals who really need that additional support, who are not getting those supports and those services. We also have our WIC program, which is really for pregnant women and children who really need additional nutrition support. And unfortunately, WIC is only reaching 50% of pregnant women who are actually eligible for the program as well. And not only are we only reaching 50%, but after the age of 2, the participation on that program decreases drastically. And we lose a lot of children who really need those programs. You know, over the last several years, there's been some great intentional work that USDA has been doing with medical services as it pertains to WIC and to SNAP. I had the opportunity a few months ago to go to Colorado to see one of our sites, which is a co-location site, and we have them all throughout the state, in which staff are co-located within the medical fields and medical offices. I got to witness a mom who showed up for an appointment for pediatrics. It was like her daughter's 3-month check-in. And while she was waiting for the doctor, through some USDA grants and funding that we had available, she was actually able, the nurse, after she weighed her and got her all ready for the doctor to be seen, was actually able to page a WIC specialist who came in and did eligibility determination right on the spot. So the nurse who was checking in that mom had read in the notes that the doctor said that the child needed more milk, right? Additional supplements and services. And so did the mom as she was breastfeeding. And it was just beautiful to see that she didn't have to try to go navigate through this, convoluted process that we currently have in place, right? All these different federal programs to get services. And so we've really been focusing on increasing access. And what does that look like throughout the country? Because it looks very different. And it's through collaborations with physicians, with insurance companies, partnerships with states who currently operate Medicaid programs, which most of our states, the majority, over 40 of the states, operate. It's the same staff who operate SNAP and Medicaid in our states, and who have great partnerships with WIC. And so they're able to do some intentional program alignment and try to do as much as we can when we talk about conferring eligibility or trying to reduce the administrative burden for individuals who are trying to apply for our programs and services, because we recognize that's a huge challenge. And so we've done a lot of intentional partnerships, intentional work on making sure that people are aware of the programs and that people have access to the programs. One of the areas that we've also been focusing on when we think of access is, a lot of our populations live in areas that are rural. And so how are we ensuring that those rural populations are actually able to not only get the SNAP benefits, but actually be able to purchase food, right? I can tell you in the state of Louisiana, I can go to almost every parish within the state outside of New Orleans and Baton Rouge, and you will see that there is not a grocery store. Like some of them have a Dollar General, right? So it is more or less, how are we able to really support and partner with those individuals who need healthy resources? We took, prior to the pandemic, I think it was in 2019, we launched our SNAP online purchase, which some of you may have heard of, which is actually now in every state in one territory. And so individuals don't have to leave their home. They get incentive offers through ordering online, through Amazon, using Instacart, their local grocery stores, so that they can actually purchase healthy, nutritious food and have it delivered to their home. And a lot of states partnering with agencies like Instacart on making sure that they get their food, their healthier food options, the fruits and the vegetables delivered in, within a certain hours of a window. We also have programs like GusNIP, which some of you may be familiar with, which is a food and fruit and vegetable program that we have that is very much sometimes partners with our local farmers markets that we support throughout the state, and giving individuals opportunities to really have options to do match bucks or similar type of programs where we will match the SNAP dollars so that they can double up on what they can actually afford. And those work in states that are doing such great work already, especially with the 1115 waivers, as really just trying to give additional supports and resources for individuals who don't have enough food to eat. We all know that, the average household, like I said, their benefit amount for one person is $281 a month. And it comes out to about $2 a meal or $6 a day, which is not a lot of money for individuals when they're trying to make nutrition decisions, especially if they live in a rural area where they go to a store and it costs $6, $7 for a gallon of milk or a carton of eggs. And so it is really working really close with and understanding allowable waivers and flexibilities within the federal government so that states can operate programs and really tie together all of these programs to make really holistic services for individuals and families and to meet the needs. For years, USDA has also operated a SNAP nutrition and education program, which has really been focused on increasing healthy eating habits and physical activity. A lot of our programs, of course, are administered by state agencies, but most of them are operated through a lot of community-based organizations, right? So it's the community kind of knows best. We all know that a lot of people don't like to go to the federal government for help, but they will go to a community partner or friend to actually get resources and support. And so it is a lot of work of making sure that there's resources and supports within the community so that individuals know how to cook certain meals, fruits, vegetables that they haven't particularly maybe have eaten before. Additionally, it's an increase that you'll see in the amount of support that's going on farming and even on school gardens and school meals. You think of the child nutrition programs, just the school meals that are, that we provide funding for on a daily basis for all children that are in school. And some of those schools have had the opportunity to partner with local farmers and actually do community gardens, using SNAP benefits to purchase seeds so that individuals can actually grow their own fruits and their own vegetables. But then when they do that, how do they prepare those fruits and vegetables? And that's a lot of what SNAP nutrition education does, is it really teaches individuals how to make healthier choices, how to prepare some of those meals, and also how to shop on a budget, because like I said, SNAP does not provide a lot of benefits or a lot of food assistance, definitely not everything that individuals need. There's a lot of other programs that we are currently offering, a lot of intentional work that we're doing, especially around being creative on innovative approaches in which we can really address or increase food security within our country. And I think there's a lot of states that are actually leaning into those efforts on really trying to increase access and making it less of an administrative burden and a process for individuals to access the food program just to have their basic needs met. So I think I will stop there and hand it over to you.
Thanks, Shavana. I want to pick up on that theme of holistically supporting people. And Richard, I think that's a really nice segue. If you could share with all of us a bit similar to what Shavana just did around what HUD is trying to do in this space, sort of an overview of what HUD offers and how that integrates with this conversation here around serving Medicaid enrollees.
Sure, happy to. So my name is Richard Cho. I'm the Senior Advisor for Housing and Services, and I work for the Secretary of HUD. And let me tell you a little bit about the range of things HUD does. You probably know about HUD in some specific ways, but we play a number of roles. And I think one of them is we insure mortgages for homeowners as well as for people who are developing healthcare facilities and other programs. We also administer various forms of deeply affordable rental housing that's either providing assistance directly to households so that they can rent apartments on the private market, or where we actually subsidize buildings or subsets of buildings to keep the rents affordable in those buildings. We provide money to help communities to build more housing or to redevelop neighborhoods and communities, and particularly in urban areas. And then, of course, we play a major role in addressing the homelessness crisis, and where we provide grants and other resources to help directly assist people who are experiencing homelessness, and to some degree, those that are at risk of homelessness. For a number of the people that we touch, we know that housing assistance is only part of what they need. And in fact, what they also need is wraparound supports, not only to stay in their homes, age in place, and actually to be able to live independently, but many people actually aren't even able to access our programs and obtain housing assistance because of their lack of supportive services. And so my position actually was created during the Obama administration as a position within the Office of the Secretary. And the entire charge that was given to the people in my role, and that I'm honored to currently serve in this role, is to basically find ways to link with other federal agencies and other systems so that we can ensure that people are provided with the kind of supportive services, healthcare supports that they need, so they can both access housing as well as stay in their housing. And so I think just
I've just been, it's been a huge treat to be able to work with Aditi at CMS because in many ways, I think the partnership that we have is a reflection of HUD's recognition that there are people out there who need a combination of housing and supports in order to fully succeed. And so the focus on health-related social needs and housing as one of those is just really critical. We do fund some supportive services in our homeless programs, for instance. We actually also provide some grants that pay for wraparound supports in as part of housing programs or even independently. But it's all ultimately a really tiny portion of our spending and our budget. We also fund service coordinators who work within our older adult housing or housing for seniors, and their job is Herculean. It's basically a one person in a building who's often trying to chase down a number of different healthcare interventions for older adults so they could prevent falls, so they could help people with medication management, essentially to prevent them from institutional care. But in many ways, we're often paying for a really tiny portion of the kind of services that people need and putting the onus on case managers and service coordinators to have to chase down the much bigger kind of healthcare supports that we need. And so a different way that we're approaching that is by trying to find and leverage partnerships with other sectors and services. I think the place where we've done that the best is in a program that we have for homeless veterans known as the HUD VA Supportive Housing Program. And I think once in a while, Congress does something really smart, which is to create a program where they're giving money to HUD to pay for rental assistance for veterans who are homeless, to transition them to permanent housing, and also appropriating money at the Department of Veteran Affairs to provide case management services for homeless veterans. So it comes as a package, funding to 2 different federal agencies, and essentially a veteran who gets HUD VASH assistance gets a rental voucher, they can move into a private apartment, and they get a dedicated case manager that is plugged into the entire VA healthcare system and network. And I think in some ways that's the kind of gold star Cadillac example of how we can pair housing and services. Now, people often ask us, why don't you do HUD VASH for other people who are homeless or basically like any other population that needs housing and services? And we were like, we would love to be able to do that if Congress was to find a way to do that. But as we know, there's not a sort of government-run integrated healthcare system for the majority of Americans, particularly those that are low income. So we have to work within the systems that exist. And I think the biggest opportunity is within Medicaid. And so when I hear about examples like Massachusetts and California, where the Medicaid agencies are recognizing that if they can have Medicaid cover the kind of wraparound supports that people need to move into housing and to stay into housing, and that's paired with housing assistance that's provided by HUD or perhaps a state agency, that's essentially how we get to that combination of housing and services. And so for us, and particularly my role, is figuring out how do we work closely with CMS and other partners and support states in aligning what can be done under your Medicaid programs to cover those housing-related wraparound supports, but essentially use that as a way to complement and supplement what HUD's role is, which is to pay for rental assistance and to pay for the capital to help build more affordable housing. So maybe I'll pause there, Aditi, but happy to engage you more.
Thanks, Richard. Jacey, let's bring it back to the state perspective. How is that translated for you all in California in terms of the problem that you saw that I think we've all sort of identified, how you scoped those services, how you worked with stakeholders to get to where you are?
Good afternoon, everyone. Jacey Cooper, I'm the state Medicaid director in California. So we, really looked at about a decade ago, we started really looking at data and we did a pilot. We definitely saw that 50% of our costs were coming from about 5% of our beneficiaries. When we dug into the data even more, it really came down to people at institutional levels of care or at risk of institutional level care, people experiencing homelessness, your most complex. And almost all of them had some level of social need or health-related social needs also at that intersection. So after 5 years of learning a lot, we moved forward with both the in lieu of services and the 1115 for what we call 14 community supports. And it is essentially a suite of both housing services and or services to keep someone safely in their home with wraparound services. So I'll kind of break it down how we got there and then the process for stakeholder engagement. So I'll start on the housing and homelessness side. So we essentially looked at it and said, the ACA was amazing and expanded access to a large number of people, and some of them didn't actually have the full continuum of care. So someone experiencing homelessness goes into an emergency room multiple times, eventually gets admitted, and then can sit and languish in a hospital bed for sometimes 6 months. That's a really expensive bed. We could pay for a lot of housing not in a hospital bed. So how do we make sure that we're building a full continuum for somebody? Every person in our program, we feel like should have a full continuum of care available to them at any given point in time. So what does that look like? So we have put forward what we call our housing bundle, very similar to what Gary was describing, where it is housing navigation services, deposits, including first, last month's rent, furnishing, et cetera, as well as those liaison services. Once someone's housed, you need to keep them housed. You want to make sure that they can stay successfully in that home. So those liaison services. We also cover what's called medical respite, or what we call recuperative care. So somebody leaving a hospital, an emergency room, it also can be a community admission for someone maybe who's diagnosed with cancer, experiencing homelessness, putting them in through recuperative care. And that's up to a 90-day period of time that they can stay, get medical care, of course, housing, food, everything. We also cover what's called short-term post-hospitalization. So that's 6 months period of time. You can also double up on that. You can go from recoup to short-term, or short-term to coop, I can't remember what the piece is, and essentially get 9 months of both clinical services, housing, food, et cetera. What we do in those programs is then we embedded what's called enhanced care management. So somebody who's linking them to permanent supportive housing, temporary housing, and or some housing pathway as well, which is really, really critical. So now we have the full continuum of services for somebody to be able to successfully heal in an environment, because somebody who's being discharged from a hospital with a wound, they're not going to be able to heal and recover on the street. And so it's critical that everybody has a place to heal. And it is very clear, we've had an independent study in California, I know Arizona and other states have too. It's not just medically appropriate, clearly, but it's cost effective. We're actually demonstrating that even by investing in those additional housing services until somebody gets a voucher, gets into their home, it's costing less money overall for that individual. And there's a demonstrated reduction of emergency room visits, inpatient stays, and or going into a skilled nursing facility. So the idea behind our community supports is providing somebody care at the lowest level possible and not putting someone in institutional levels of care or taking hospital beds when that is not what is needed for that individual. They just don't have a home to recover in. And so we've really built out that continuum in a real way. We also then took another lens of, a lot of the things in our 1915C waivers, you have to meet an institutional level of care. All of ours in California are statewide. Infrastructure, we didn't have that across the state of California. And so we essentially put almost all of our WRAP services from our 1915C waivers into in lieu of services. So if you're familiar with Money Follows the Person, the federal program, we also just essentially built that into an in lieu of service to be able to take someone from a skilled nursing facility or institutional level of care, transition them to a home, or transition them to an assisted living environment, and paying for that transition, including the home deposits, home modifications. So we do home modifications for anyone to be able to stay safely in their home or reside in their home, as long as that's the best place for them to be. And so those are included. But we also are looking across, how do we continue to have somebody stay safely in their home and community if that's what they and their family are choosing? And so we are covering things like caregiver respite is included. So for both children with complex medical conditions or older adults who need caregiver respite, sometimes that's really needed for them to reside safely in the community with their family or their circle instead of going into an institutional level of care. So covering that through our in lieu of services is allowing all of these various WRAP services to be available and being available slightly earlier than they would be if you are narrowing it to a 1915C. And so that's kind of our full kind of package. We also include asthma remediation in there as well. And so you'll see across those community supports, some of them are immediately in lieu of a higher intensity service, but some are preventing it as well. And I think that's the beauty with the new health-related social needs. It doesn't always have to be an immediate replacement. You can demonstrate that it is a preventing a service. For asthma remediation, for example, you're preventing a future emergency stay or inpatient stay. And so I think that's one of the nice flexibilities that we have seen in regards to it, because that's really critical to do. And you can't always do that with the 1915C, right? So I think it gives that ability to be more upstream, which I think we're trying to do, being more upstream in regards to providing interventions, because that's really where you can see the cost curve in a very real way, instead of waiting till somebody really gets sick and you pay that money if you intervene earlier. Now it's a sweet spot in regards to eligibility, and that's one of the biggest parts. So we did over 2 years of stakeholder engagement in California. It was brutal for the record, because you're bringing health world together with people who have not been in the health world. And then you're bringing community-based organizations who are like, Medicaid has too many rules. You want us to do too many things. Stop it. And it took a really long time to build partnerships and to understand. So we built this all into our managed care plans. And so we've built that eligibility criteria. So we have eligibility criteria for each of these 14 community supports, and we've vetted that over that period of time. It took a lot of, fine tuning. And what I would say is we're still fine tuning now that we're live, because you learn a lot once people are in it. We also had to provide providers. I think the biggest thing though is we didn't have this infrastructure across the entire state. Some had been being paid for by philanthropy or foundations, or counties were putting up programs. But we in our 1115 put in a pretty sizable, what we call PATH, providing access and transforming health dollars. And that was to pay for actual infrastructure. So we are in the process of doing infrastructure build across the entire state of California to build up the providers. And we have actually increased every quarter over 40% of providers coming on to provide these services across the state of California. And we anticipate it will grow even more as our PATH dollars go out over the next few years. So essentially building statewide provider infrastructure so that people in certain counties, rural counties, who would have never had access to these services before, where we couldn't really do it as a full statewide benefit, will be able to flip from in lieu of to an actual full statewide benefit, because we'll be able to demonstrate that anyone who needs it can actually have access to those services across the state. So that's the goal. Is in the next few years to flip everything from in lieu of to an actual statewide benefit, with the exception of things that have to be in 1115. We would still probably flip that to be a mandate instead of an option, because right now it's optional. But even though it's optional, for example, that housing suite is in all 58 counties in the state of California. So we saw such a significant increase in need of demand that we've really been growing at a significant rate. But we've also, when we're working with our managed care plans, I think that's one of the biggest stakeholders is, they're used to authorizing surgery. Guess what they're not used to authorizing? Housing services, supports, nutrition. We also cover medically tailored meals and medically supported foods across the entire program. Sorry, I didn't mean to leave that one out. And so that is new for them. And that has been probably one of our biggest pain points, because as we've told our managed care plans, I don't want you to go and provide surgery. You contract with somebody who provides surgery. You contract with surgeons who do that. I don't want you to be the person who goes and provides these housing navigation services or doing this. You need a contract with community-based organizations and experts in the community who do this. And so I think this has been a long evolution of getting here. We learned a lot in the first year and a half of being fully live across the state of California. And we're in the process of doing pretty big tweaks off of our lessons learned from the first 18 months. And so look forward to kind of digging in with our partners as we kind of take this to the next phase in California.
Awesome. Thank you all so much. It's striking to me, we're at a health equity conference, right? It's in the title. And so much of this work feels inherently rooted in the idea of advancing health equity, but I'm wondering if you all can reflect on what it means to bring explicitly an equity lens to this work. And that's a sort of open question. We're going to transition now to more sort of popcorn fire style chat style. And I promise to incorporate some of your questions as well.
To jump in, I mean, I think just if I can get on a soapbox, I would say focusing on housing and the people who are unhoused or experiencing homelessness is the best way to address health equity. The vast majority of people who live or are assisted by some form of HUD supports, whether it's people living in public housing or who have a housing voucher or homeless assistance, are Black, brown, or people of color. A significant portion are indigenous. if you think about homelessness just as a subset of that, and I think California is a great example of just how big the homelessness crisis is in California. Essentially, if you think about that as a subset of Medi-Cal beneficiaries, right, or people experiencing homelessness, their entire healthcare system is homeless shelters, homeless outreach programs, soup kitchens. It's so essentially like their safety net and their healthcare system is essentially the worst funded form of social services that exist in our country. And so I think just thinking about what they have access to as opposed to what other Medi-Cal beneficiaries have, just equalizing that means you need to figure out how to get people into a form of housing that they then can get plugged into the kind of healthcare system. So I would say, just even paying attention to housing status and the homelessness aspects of people who are Medicare beneficiary or Medicaid beneficiaries is a huge kind of step forward in understanding health equity, because I believe housing is probably one of the most important social determinants of health, because where you live determines everything else. Your access to environmental quality, your access to education, employment opportunities, your access to food.
I'll just tag on to that. So in California in particular, I agree with you. We have 170,000 people experiencing homelessness in any given day in California. That's probably understated. That's more than we have in SNFs. But look at all the infrastructure for people in skilled nursing facilities. Like it's been long underfunded and paid attention to. And in addition to that, 39% of people experiencing homelessness in California are Black. Only 7% of our population in California is Black. So it's clearly disproportionately higher in regards to the population. So one of the things we did in California is we built in what we call a housing and homelessness incentive program. So we're actually incentivizing community-based organizations to target individuals who are Black, African-American, and we have a very large Indigenous population as well. And we have seen in the first year of all of the community supports provided across the state of California for housing and homelessness, over 45% are for individuals who are Black. So we are seeing a large in the grand scheme of all those experiencing homelessness. So we are seeing targeted interventions, but it has to be targeted in order to actually do those pieces. We're also intentionally funding providers who can better meet the needs of individuals across the populations that have the highest disparities, and making sure we're partnering with CBOs who can be trusted partners on the ground for us to actually bend that curve. It will take very intentional actions, in my opinion, to be able to look at this. When it comes to food insecurity in Los Angeles, for example, 40% of people in Los Angeles are essentially food insecure. That's a huge number of people, and that's dominantly Latino population in Los Angeles. So the need here of being able to really focus on in the intersection between health-related social needs and equity work to really break down disparities and be able to move the needle is, in my opinion, one of the most important pieces of health-related social needs work.
Yeah, so also to piggyback off of that, the disproportionate rate of folks who are homeless who are also Black and brown is similar in Massachusetts as well. So one of the ways that we've really tried to incentivize folks to incentivize our health plans to really pay attention to trying to provide care for folks who are homeless is by incorporating the state of being homeless as a consideration and how much money a health plan receives to provide care for that individual. This is through something called risk adjustment, right? Where basically we predict how much money it will cost to provide care for an individual based on various characteristics. And if someone is homeless, then the health plan will actually receive more dollars to pay for services for that individual. So just one sort of financial lever that we're taking to call attention to that particular aspect. For the flexible services program, that pilot program that I was talking about, we've been requiring our ACOs to look at the racial and ethnic breakdown of people who are receiving flexible services compared to a similar group of folks, to see if they're actually administering this program in a way that is equitable. And so this is something that the ACOs, they have to do analyses and send it to us. And then recently, we've also rolled out a requirement where it's not just looking at folks who access flexible service, but what's the breakdown by race and ethnicity of the actual outcomes, so health outcomes for people who are receiving these social supports. The final thing that I'll mention is, in order to do proper slicing and dicing of the data by race, ethnicity, and other demographic fields, we need to have robust data for that. And so this is a major area of focus for Massachusetts as authorized in our 1115 waiver. Through that waiver, in addition to the housing nutrition supports that I just described, we also received approval for a $2 billion incentive program for our acute care hospitals called the Hospital Quality and Equity Initiative. And this is an effort to advance health equity among a bunch of different domains, but one of them is improving the collection of race, ethnicity, language, disability status, sexual orientation, and gender identity demographic data. And the goal here is to actually put dollars into the pockets of hospitals who are able to demonstrate and reach certain levels of data completeness. And then we're also implementing a companion program for our accountable care organizations and our more traditional managed care organizations to also try to achieve higher rates of data completeness. So we're putting financial incentive dollars to increase these rates, which we believe will allow us to better assess the disparities of folks who are engaging with our MassHealth system.
And I would just add, there's a lot of intentional work that USDA is doing. One of the things that was just released over this last couple of months was an equity report. And so the department established an equity commission that actually was tasked to really looking at equity throughout all of the USDA programs, which really led to all of the program areas coming up with a plan on how they're going to be addressing equity. We look at policies, at practices and guidance, since a lot of our programs are not delivered by the federal government, but by the state agencies, but the information that we're putting out there to support states in the operation of, for example, like the SNAP program. We get a lot of, we have a lot of conversations with individuals who are in rural areas who really just want a grocery store, right? So how are we going to help to increase access to those healthy food options? And so how are we working with vendors and contractors and big corporations to see if they can go in and help and support some of those rural areas to give them better opportunities. I talked a little bit earlier about even the SNAP online purchasing, which was an equity effort that was put forth to make sure that everyone had the same opportunity with purchasing and their purchasing power of, food and nutritious, nutritious foods, I think is what I was trying to say. And so there is a lot of intentional work, I think, that's going on. We're doing a lot of looking to see who is on our programs, what populations are we missing from our programs. I think you both spoke to it already, but there is a large population of Black, Indigenous, Brown folks who are not receiving SNAP benefits, who are eligible, huge senior population who believe that they're taken from somebody else if they're actually on the program as well. And so it is more or less providing good guidance and information to the public, to states as they implement these programs so that we can increase access and make sure that everyone has those same opportunities.
Thank you all. We've got about 10, 15 minutes for questions. I have many more questions, but wanted to take the opportunity if there are folks in the room that wanted to ask a question of our panelists. We've got a mic up here, so just raise your hand and we'll get a mic to you. Please do introduce yourself as you're asking your question.
Hi, it is on. Hi, Kate Johnson. I'm at the CMS Innovation Center. Thanks. This has been really a wonderful panel so far. I'm curious, it seems to me a key piece here is really around collaboration with community-based organizations. And I think, you touched on sort of network adequacy or really like the challenges of MCOs in California in sort of figuring out how to procure these services. But I'm curious if you have perspective on sort of federal facilitators for that challenge.
Interesting. Can you say a little bit more when you say federal facilitators for that challenge? Because there's a lot of challenges there. I just want to make sure I answer your question.
Yeah. Yes. I guess I think we've heard a little bit in our accountable health communities model around sort of barriers for community-based organizations to sort of get federal funding from multiple sources and like braiding and blending those funding. So I guess I was curious from your perspectives, what you're hearing from your stakeholders.
Yeah, no, braided funding sounds great till it's not. At the end of the day, we are asking people to do significant braided funding. So even if you look, at least in California, there are different even state agencies who provide all of the services shown on this thing, and then at the federal level too. And while we are really trying to bring everyone to the table, so we even did that housing and homelessness incentive program, for example. One of the things that we required our managed care plans do is they had to join their local continuum of care. They were required to essentially have a seat at the table for any HUD decisions or any local housing and homelessness decisions, so that they were weaving themselves into the system. One thing we said is you don't get to just go make your own system because that won't work. And we are trying to work across our state agencies and you can see here federal agencies, but I still think that there's a lot of work. For example, we're only one piece of the large homelessness puzzle. To be honest with you, I can't, in Medicaid, I can't do it all. I can't pay for every piece along the continuum. And so it does require community-based organizations to work across, and we've been trying to do a lot of that. We in California have a interagency housing and homelessness council where we work directly with our housing partners to figure out how can we start breaking down silos or advocate up to our federal partners around where we're seeing federal regs or pieces that are not allowing us to streamline. I think that as more and more states get into the whole like health related social needs, I think we'll see more movement there. But I do still think there are both federal and state policies that will need to change over the next decade to see this really come to what it can be. For example, we can pay for the housing navigation services, but if I can't get someone a voucher, I'm in a bad spot. And we actually had a case in California where somebody had been on short-term post-hospitalization in recuperative care. They were sitting there, they could not get a voucher in time. And so we essentially, the county we're lucky enough, Los Angeles has a very large, what's called Measure H. They pay for a lot of additional services and they paid with county funds only to keep them for the 2 months more longer they needed to get that voucher and then to get them into housing. Because we only pay for 9 months, but the average time from identification to voucher or housing can be anywhere from 8 months in some counties up to 18 months in certain counties, because we have a huge housing access issue in California too, right? So this is where all of the players coming together is really, really critical, and where braided funding can be really good because you have to use it within the restrictive chains. You have to have really sophisticated community-based organizations to do this as well. And there's not a ton of those, to be honest with you. They're growing more and more. But I think that's one of the biggest challenges of this work, especially in states that are going into this new. It has been a huge learning curve. And then on top of that, telling them to bill Medicaid, they leave the room.
I just quickly add to that because that's such a great, I want to applaud that answer. That's such a fantastic answer. The fact that you even sort of like are trying to get the managed care to work with continuums of care, that's a huge step, right? And I think this is the problem with doing kind of cross-sector work, is that we can sit in our own sector and talk with, go all day using acronyms and understand the complexity of how our systems work and how, yes, you need to get authorization for that service in the healthcare space, right? And then I hear all the time from the healthcare folks, they're like, why can't I just prescribe housing for my patient? Why can't I just like call up a number and get this person housing? And I'm like, that's not how it works on your system. Like, why would you think the housing system works like that? We have a whole network ourselves of how you have to allocate the services. So, you got to understand that we like the homeless services system are organized into 386 different continuums of care in the country. That's just like the collaborative bodies that manage access to homeless systems. Vouchers, public housing is administered by 3,000 plus different public housing authorities across the country. If you understand that network and then create the incentives for healthcare system to be able to work with those existing agencies. So we at HUD have been working really closely with HHS to try to help connect the dots at the state and local level some more. We partnered with CMS and the Administration for Community Living and a few other HHS agencies to stand up a housing and services resource center. And it was meant to be a kind of like one-stop shopping webpage resource center, webinars where you can get information on just how to even understand where those systems are and how do you begin to align things at the state and local level. We're also looking at how we can do some more hands-on assistance at the state level to connect the dots between states that are adopting housing related services and how to blend and braid that with HUD programs. We're also doing things like trying to issue guidance to our homeless continuums of care and public housing authorities. Like, here's how you can align your own policies for how you determine who gets access to housing assistance in what order, with ways that Medicaid is aligning their resources. So one of the things we're working on, so your homeless system has something called coordinated entry. It's their way to sort of organize who gets priority for different types of housing and how do we match people to the right level of rental assistance that people need. And what we're trying to do is send a message to continuums of care. Your state may also be adopting these new Medicaid services. They are trying to determine who's medically appropriate to receive housing related services. How do you think about determining how you prioritize people for housing assistance in ways that matches up or kind of coordinates with the way that people are deemed eligible for medically appropriate housing related supportive services? So we're doing things at the federal level to try to make our policies kind of mesh together with the way Medicaid policies work.
There are a couple of threads that Jacey and Richard both talked about that I'd like to follow up on. So when you were talking about your PATH program and how you're hoping that will actually increase the capacity of your CBO partners to become Medicaid sort of providers, if just for lack of a better phrase, and then you were mentioning these resources that you're making available. Like I think one of the biggest issues is these community-based organizations. Oftentimes they're really small. They don't have expertise to know, like, what does it mean to be a HIPAA compliant entity, right? When they're contracting, when they're trying to provide services, when working with these health plans, they may not have actually any experience with operating in a model other than a philanthropic model, right? So what does it mean to actually sign a contract with this large organization when they don't even have a lawyer on staff, right? So what is it? So what would it look like to provide resources to these community-based organizations around contracting, HIPAA compliance, data sharing, working with IT systems that are more common in the healthcare space? Another topic that I'm thinking about is it's sort of the flip side of what I just said, which is that a lot of medical providers know nothing about the housing world or the nutrition world or any of the other social services. I mean, they may have social workers or other extended care team staff, but the leadership of these organizations may not know anything. So what would it look like, for example, to have monthly webinars that HUD or USDA puts out for medical providers across the country to learn about the housing world and the nutrition world? You know, that would be so, I think, valuable and would help to really accelerate the momentum towards better integration of these sectors. The last thing that I'll say is around how does the medical world actually refer people to social service? Like, what's the actual modality, right? So a lot of times people will make a phone call, but more and more there's electronic capabilities to be able to do this. And there are a number of these HRSN referral platforms that are out in the wild. This is what happened with EHRs a while ago, and they're not interoperable. Like, how can we get them to all work together to be able to send messages from one platform so that all the other platforms can also receive them, so that a CBO doesn't have to have like 10 separate logins for different platforms that different healthcare providers are partnering with them. And so it's something that some states have tried to deal with by procuring a single statewide platform. That is one option. What does the interoperable option look like? And is there a role for the federal government to play to actually convene these players and actually create a system that isn't going to look like what EHRs look like today?
Yeah, we have time for some more questions. Can folks hear me?
I think we have time for one more question.
Okay, I'm gonna let Caroline decide because that seems like a tough job. Okay.
This may be more of a comment based on what you were just saying about interoperability. So as a part of our SIM grant in Michigan, which, you know, we concluded a while back, our communities have been working on trying to create an interoperability so that we've got closed loop referrals so that physicians can make those direct referrals into a human service agency and then hopefully get the data back that says that, yeah, we found them housing, or yes, we got them the food that they needed. One of the barriers that we've encountered is that, especially with the merger of large hospital systems, the hospital systems themselves, as you say, are sort of buying these things that allow for resource referral, but you're not getting the information back. And the only way this is going to work is if we can also nudge the hospital systems to work with community so that we're able then to really put those sorts of closed loop referral pieces together. And that is a barrier. And especially the more these guys merge with multiple hospitals in multiple states, it's becoming very difficult. And that really, I think, speaks to a federal issue in terms of what can the federal government do to encourage the hospitals to behave differently, maybe.
That's helpful. I think maybe we have time for one more. Okay. All right. I'm being told we're at time now. But we're happy to stick around. Thank you all for joining us. Thank you again. A round of applause for our panelists. We'll be here. Thank you.